All right, guys. So today my project is going to be about total knee arthroplasty. My name is Kaiser Mitchell. All right. So the pathology for this disease is usually going to be caused by osteoarthritis. What happens is the cartilage in the knee starts to deteriorate, and you start to get that bone on bone. If it's not osteoarthritis, it could be by a couple of different um, other underlying conditions: knee deformities, rheumatoid arthritis, avascular necrosis. Just it really just kind of depends on how the patient presents. If they're getting like a lot of inflammation, that may be a sign of inflammatory arthritis. And if they have, that frequent pain and that joint dysfunction, that you could be looking at osteoarthritis. So it just kind of depends on um, how the patient presents. All right, so if we look at this picture, we see what a normal joint space look like, and we see what an arthritic knee joint space look like. You can see the joint space is really small. You don't have much room, and you start to get that bone-on-bone contact. In this picture on the right, you see an arthritic knee, and you see a knee after knee replacement. So whenever you get that bone-on-bone contact, that's usually when you need to get a TKA. So the surgery is done by an orthopedic surgeon. You're going to replace the femoral condyles, the tibial plateau, and the kneecap once it's worn down. Um, a metal cap is placed on the distal femur and a metal tray on the top of the tibia. And you also use a spacer in between the two to kind of be able to go back and forth. So here are some just quick statistics. One thing to note is females are at more risk than males for a TKA. Over 4 million people in 2010 had a TKA. And since the 1970s, when this procedure started, late 1970s, that is, the lifespan for implants is about 15 to 20 years. Populations affected usually going to be an older population, 65 to 70, but we're starting to see more middle-aged people have to get these as well. So some of the medical interventions, um, so you basically have pre-op medical interventions and you have post-op. So pre-op, you want to get them the anesthesia, you want to get them the nerve block just to make sure they don't have too much pain, make sure they're out of it, they can't feel anything. Um, and then post-op, you want to administer that nerve block as well, and then start taking pain meds, just depending on the severity of the pain. A lot of patients report that their nerve block may last up to a week. Some people, it doesn't last as long. You want to also make sure you're getting the patient on antibiotics because this is a very high risk for infection. Surgery and monitoring vitals because patients do lose a lot of blood fluids. So this is where we come in. Our interventions are kind of based on the phase that they're in. If they're in acute phase, you have certain interventions. And if they're in a phase 4, when they're about to return to their prior level of function, you have certain interventions. Some of them overlap, but we'll go through each phase and see. So during phase 1, you want to focus on reducing pain and swelling. You could be using ice right here. You want to do some gentle range of motion, some passive gentle range of motion, try to get some flexion back in that knee, at least 80 degrees and 10 degrees on extension. And you also want to just slowly start strengthening the lower extremity. One really good exercise to do right here is short arc quads. Those are really good as well. Next is phase 2. This is when you're going to try to get a lot more of the motion back. You're going to go from 80 degrees to 100 degrees of flexion, and you want to be able to get at least 0 degrees of extension. Some good exercises, interventions you can do: stationary body, no resistance, quad sets, heel slides, straight leg raises, and working on patellar moves to get some of that motion back in the joint. Also, in phase 1 and phase 2, you want them to be ambulating with a walker, or especially in phase 1, ambulating with a walker, and phase 2, kind of weaning off of it. Um, Another really good intervention to use during phase 2 is soft tissue moves to kind of decrease swelling, get it going back towards the heart, and also decrease stiffness and improve flexibility in the quads and hamstrings. In phase 3, you're getting into more functional stuff with the patient. You want to do sit to stands, mini squats, still having them walking. And you also want to really up the strengthening, doing things like leg presses, working on a matrix machine, doing long arc quads, knee extension, and hamstring curls with resistance is really good right here. You want to be able to get that patient to a 4 out of 5, 4+ or 5 on their main muscle testing. During phase 4, this is the final phase for us as therapists. This is where we're trying to get them back to their ADLs and functional activities. We're working on balance. We're working on proprioception. We're working on stability of that knee. Right here, like I said, we can do leg press, lunges, resisted cycling, and even walking, jogging programs, depending on the goals of the patient. So phase 3 and phase 4 is going to be heavy on strengthening, heavy on functional stuff. Some interesting facts about a total knee is when I talk to patients, a lot of patients say that the first total knee they got versus the second knee, the first one was better. They was in way more pain with the second one. Some patients feel pain at night when they're trying to sleep. Um, After interviewing patients, their least favorite exercise that I get across the board is when they're doing a prolonged stretch with their uh, foot propped up on a chair. They literally hate that one. So that's interesting. Why I chose this, this is probably the most common diagnosis I've seen since I've been in my rotation. I also got to watch a surgery during one of my rotations, so I just really took a liking to TKAs, and I hope to be able to help patients in the future.